Welcome to the Listen Up podcast, where we explore hearing loss, communication, connections, and health.
Hey everybody, it's Dr. Mark Sims here. I'm the host of the Listen Up podcast, where I feature leaders in healthcare. This episode is brought to you by Arizona Listening Center. I help patients to effectively treat their hearing loss so they can remain independent and better connected with their friends and family. The reason I'm so passionate about hearing loss is because I've lost my brother Robbie twice. I lost him first to the hearing loss from radiation to his brain tumor, and later when he succumbed to the tumor itself. I am an ear, nose, and throat doctor who only treats ears. I'm the E of ENT, and we have another one who our guest is today. I'll introduce her later. I'm also the founder of Listen Up Hearing Centers. I wrote a book called Listen Up, A Physician's Guide to Effectively Treating Your Hearing Loss. If you want to learn more about that, go to listenuphearing.com. I'm excited about our guest. We have Dr. Maura Cosetti. She's part of my tribe. She is an otologist-neurotologist. She is the director of the Ear Institute of the New York Eye and Ear Infirmary of Mount Sinai and the Cochlear Implant Program at the Mount Sinai Health System in New York. She's a leading otologist, and she's board certified both in otolaryngology, head and neck surgery, which is a long-term for ear, nose, and throat, as well as neurotology, which is specializing in the ear. She went to medical school at University of Pittsburgh and did her residency at the New York Eye and Ear Infirmary. She did her fellowship at NYU, New York University. She's the fellowship director and the director of the Ear Institute at the New York Ear and Eye Infirmary at Mount Sinai. She provides diagnostic and treatment options for individuals of any age with a range of hearing imbalance disorders. Interestingly, her research focuses on the outcomes and the use of virtual reality for the understanding how hearing loss affects postures, falls, and balance. She's got some really cool stuff going on. She's a member also of the Hearing Health Cooperative, Collaborative, which is one of the ways I stumbled into having her as a guest. Maura, thanks for coming on. Welcome to Listen Up.
Well, thank you. Thank you so much for having me. Really an honor.
Yeah, great. And so we did fix the Wi-Fi problems, and we were having a little sputtering before, but it seems like we're doing great. So tell me about, how you ended up, going into medicine, ear, nose, and throat, and then otology, which is special. I tell patients it's the E of ENT. How did you end up in the E of ENT?
Yes, I love that phrase. I use that all the time. That's a great one. Well, how much time do you have? No, I'm just kidding.
4 hours. That's a lot. We got a lot of space on the cloud.
Right. So when I was in middle school, no, I'm just.
It all started with a rainy day.
Right. So actually, I got into medicine. I was a ski patrol, actually. So I loved doing a lot of emergency care and sort of worked on an ambulance, and subsequently made my way to medical school. And in medical school, I found I really loved surgery. I just loved anatomy, probably like yourself. Gross anatomy is one of those dividing lines, I think, in medical school, where you either can't wait to get there or can't wait for it to be done. So right. I was definitely on the former. And ultimately, as I was going through, I really loved the collaborative nature of ENT. ENT was just like the greatest combination of technology. You had the greatest option or integration of sort of anatomy, which was so complex, technology, and also literally all of the senses, and except for vision. And even vision, we collaborate quite a bit with. So I just love that part and really couldn't stay away. As they say, I think I found my tribe, much like you. So a bunch of like-minded people who get to do surgery and follow patients over a long period of time and of all ages.
I think that's huge. Cradle to grave, as they say.
Yes, exactly. And, hearing loss, we often think about it as, at the extremes of age, but that's really not true. It's literally the whole gamut. So
how'd you end up? All right. So now we're into ear, nose, and throat. So how'd you end up in the, the smaller tribe of us kind of eccentric ear guys?
Yeah, right. Exactly. And the small tribe it is, as you know, there's not. So for a variety of reasons, I think one is actually something that's now really popular in medical education is called simulation, or, getting people to practice things before you're actually in the operating room or maybe in the clinic with patients. And I often like to say that in otology, we had the original simulator, which is the temporal bone lab. And so I think I just loved temporal bone lab. I love the anatomy, sort of the precision. I like to sit during surgery. A lot of really critical factors. But and then of course I really enjoyed hearing. I think all of us, and this speaks to the epidemiology of the problem. I know certainly for yourself, as you've described, just on this podcast and otherwise, familial members who've had hearing loss and the impact that can make, I think just affects all of us. For me, that was my grandparents, my father, and the list goes on.
Yeah, it's a shame it's such a poorly treated entity. And that's one of the reasons I got interested in the people who are involved in the Hearing Health Collaborative, as you are. So tell me a little bit about your research. So in terms of you were talked about simulation, right? And so that sounds like that is right up your alley in terms of the research that you've done.
Yeah, absolutely. The research that I'm doing is in simulation in a sense. It's called, we use a lot of virtual reality. So in our field, people look at the vestibular system in really finite details. And you and I could probably go on about this. And actually, that's really not my area of expertise in terms of vestibular testing. And there's some just brilliant minds in our field that have done so much with that. And the way that we're looking at it is in a much more global sense in this concept of sensory integration. So actually, it came from, we have just a really amazing group of vestibular therapists that we work with. And we started to use this virtual reality training paradigm for vestibular problems.
Okay.
Basically, like putting people in a VR setting. I live and work in New York City. So it is the ultimate of sensory integration. Just getting to work some days, it can be an overwhelming sensory overload. But that's what our patients were telling us, not just the subway platform, which is, can be scary, but sometimes walking down the street, oftentimes it's crowded.
The grocery store is the worst.
The grocery store, right. So many things in life, not just in New York City. Yeah, exactly. And so we trained our patients using as a pilot study for something else. And we were actually testing them, but multiple patients came back and said, hey, can I do more of that? It really helped me. I felt like when I went back to that situation, I felt so much better. So really, like all good research, right? It comes from the patients. It comes from the parents in a lot of what we do in pediatric hearing loss, them asking and helping us figure out what the gaps in research and what they need. So we started with that. And then more and more, as we started to layer the various aspects of this paradigm, and as an aside, we work with people from the auditory engineering space at NYU Steinhardt undergrad. And I felt like I was channeling my 80-year-old father when I said to one of this young man, like, what are you going to do with that degree, young man? And of course, he's going to go into gaming and make like a ton of money. But during his schooling, he works with us to create these virtual reality paradigms that are very environmentally salient. So we record from all over in different settings and stuff like that. So as we were layering in these different senses, we have over time evolved a paradigm in which we test the influence or how people integrate or weight their various senses, those being primarily hearing, postural sway, head movement, balance, and different things.
So do you do testing where you compromise their hearing and see their balance?
So we started with that. And actually, much like studies that look at posture with just people closing their eyes, it's just not that. It's not as helpful or as accurate. So what we do now is we put people with we have a couple different studies, but one of our largest studies that we're doing now is a pretty controlled study where we're looking specifically at SSD, like really classic SSD. So
single-sided deafness for listeners.
Thank you. Yes, exactly. So those are individuals with normal hearing on one side and complete loss of hearing on the other side, or about as complete as we can make it. And this, I find, I don't know about yourself, but just to be a fascinating group of people. And a fascinating time in counseling, because for a good portion of our clinical lives, we basically just told those individuals, well, good luck, or here's something that you could try to route the sound to the other side. And maybe some people would decide to do it, maybe they wouldn't. And now we have literally the entire gamut of intervention, everything from observation to, as I like to say, the opposite of observation, which is surgical intervention with a cochlear implant. And so we're all trying to figure out this sort of space.
Yeah, I think that particular problem is, especially, other variables, duration of deafness, and maybe measurements of postoperative compliance becomes important. I think I don't know how good the wearing rate is. The idea seems great, but the wearing rate might be, and that unfortunately I saw with Baja as well. They're excited to rehabilitate it, and then the rehabilitation doesn't end up being what they're looking for. So pre-intervention counseling is so important. And that's actually, can you simulate some of that on your simulator?
Well, you got it. That you hit the nail on the head, which is the counseling and sort of the figuring out. And actually, that's really where I think a lot of the gap, and we're sort of as a field figuring out exactly how do we fit a given individual's
deficit
setup and deficit to the available technology. Exactly. Correct. Our sort of overarching goal is to try to figure out why people with hearing loss are at increased risk for falls. So you probably have read a bunch of that data. You've had some excellent people on this podcast who look at all aspects of hearing. Right. And that's one of the major things that we're really not sure. Large epidemiologic studies suggest that rate of falls is higher in people with hearing loss, and that seems to be linear, so that people with more hearing loss are at greater risk of falls. But why is that? There's been a bunch of different theories.
Yeah, is it cochlear vestibular degeneration, or is it that the hearing loss leads to the disequilibrium?
You got it. So that's exactly where we were. So that's why we're looking at SSD partially to the first question. So
you've got a control on the other side.
Exactly. We've got a control on the other side. These are people with single-sided deafness, and we put them through every vestibular test that we have. VHIT, VAMP, a bunch of these acronyms are just tests of inner ear vestibular.
A lot of tests.
Yes, a lot of tests. We are just
that are unfortunately not sometimes pleasant, but we'll
exactly right. That's why we're doing it in a research setting. So we're thankful to our patients and our research subjects as well, for sure. But it's really to make that argument as sound, excuse the pun, as it can be in terms of individuals without having an underlying vestibular, or can we figure out, is it this underlying vestibular deficit? I will say that it doesn't seem to be. And, part of that is that our control group, who we test on a bunch of things, they have their normal hearing, age-matched controls, have a bunch of vestibular abnormalities.
Right. And they run at general population is what you're saying.
Yes, exactly. And so, so we're trying to test out that first theory. Is it this underlying inner ear dysfunction that maybe can explain both? Is it a concept that we use sound for balance? And that's really a rabbit hole, actually, in the research world, because which sound? Rotating sounds that circle you, a stable sound. Some people call that in this area like an auditory anchor.
Yeah, I always thought, I think of like walking down the hall in a school and the sound bouncing off the wall and the ceiling, and that you are aware kind of where you are relative to that. Because that, classrooms now have carpeting, but the hallways don't. Yeah. And whenever I go to my kids' schools, I'm always amazed at how acoustically unfriendly the hallways are. And that has to do with construction costs, et cetera, et cetera. But boy, you can really tell it gives you a large sense with everything bouncing all over the place.
Yeah, you're 100% right. And now, I don't know if you've been to your kid's school recently, but in New York City, all the windows are open and for COVID,
ambient noise,
and they have all this other stuff. So it's a real minefield of hearing, for sure. But you're absolutely right. And actually, It's a field that's really sort of developing now and a really exciting one. There's been some great stuff on kids. And actually, Sharon Cushing and Blake Papson's group, they have done, these are some really experienced researchers in Toronto. And they did some of the on kids with bilateral implants. The kids, so some of their global takeaways are that when kids are profoundly deaf and receive cochlear implants to give them auditory access bilaterally, they do better on tests of balance with their implants on than with their implants off. So sound definitely
plays a role.
Stabilizing effect for them for sure. Interestingly, they, against their hypothesis, in a couple of their studies, they actually found that normal hearing kids did worse with complex sounds on. So when they put them in the same setting, and I think sort of speaks to there's probably a lot of things going on there. But the third potential etiology that we're also investigating is one of attention. And I know that that's probably something that makes a lot of sense to you. We know how much, and many, obviously many of your guests actually, and many other people are looking into the complexity of neurocognitive function,
right,
hearing. And we have another VR setup where we're doing a gait in individuals with hearing loss. And the very short take-home message is individuals with hearing loss, regardless of age, walk slower than their hearing matched controls. So age itself does not necessarily reflect some of these things, but we have a couple of different paradigms.
You're going to need large sample sizes to wash out all the other variables. So.
Well, exactly right. And some of our tasks are pretty challenging. We have a VR task where people are stepping over things and doing dual task paradigms. And it turns out that hearing loss may itself function as a type of dual task in some of these settings, just having to hear. And
it's so amazing how the field is evolving to the influence of the brain in all of this. And, you know, even in the paradigm in my time in the field, how, you know, it's so much not the ear, right? And the ear is the delivery vehicle. And then it's all this complex processing that occurs on the brain side. You know, that's, you know, when it comes to like talking about cochlear implants working, I say, well, they'll deliver the signal to the nerve. And then what your brain does with that signal becomes a very complex and hard to prognosticate thing. It's fascinating.
That's 100% true. And I think it's so interesting also when you really think about the intersection between, you know, you and I probably see a lot of people with balance problems and hearing problems. And people with balance problems, they will try anything. I mean, they are overwhelmed. It's a tremendous difficulty to go through life with a vestibular loss or to overcome an acute loss. And the converse, you and I see plenty of people who have severe, sometimes even severe to profound hearing loss who aren't that for a variety of reasons, may not be taking advantage of treatment that they know is available.
Yeah.
So it's so complicated, actually.
Yeah, I mean, you know, and that actually hits on, you know, the hearing health collaborative, right? And so that's a you know, group of clinicians who've got together to try to increase awareness and treatment for hearing. So, I mean, unless I'm misstating the goal of
You got it. You hit the nail on the head. I like to say it's actually the Zoom meeting that you're really excited to attend, which
are few and far between.
Unfortunately, yes.
No offense to everyone else. Right?
yes. It's but yes, it is run by Matt Carlson, who's a neurotologist like us out of Minnesota and an extremely prolific researcher and clinician, and Sarah Sidolowski, I may have pronounced that wrong, but she's an AUD who's really accomplished in quality at Cleveland Clinic. And they put together this group of this hearing health collaborative. And it's really a like-minded group of people from all aspects, sort of like the patient representatives and organizations like HLAA, which is Hearing Loss Association of America, and HIA, which is Hearing Industries of America, and of course, audiologists in all walks of life, and surgeons like myself in a variety of different clinical practice settings. And one of the amazing things of getting all of these people into a room is that oftentimes questions come up and other people in the room know the answer from their perspective. I mean, I wouldn't begin to know a lot of for example, market data that's been done by a lot of hearing industry kind of people. And there's a health implementation sciences researcher, which is, frankly, I'm not even sure that area was open to me when I was in training to know what that was. So everyone, and the process has been really interesting to work at globally targeting the idea of hearing loss and changing that in this country. And I'll give a very quick analogy. We had as part of the collaborative, we had someone who's an endocrinologist. And what they did in the area of obesity is actually change the concept of obesity from obesity to something called adipose-based chronic disease. And in doing so, shifted the entire treatment paradigm, the stigma, the recognition of treatment options such as bariatric surgery, et cetera. So from the nuts of screening all the way down to the payers for the interventions for these things, they tackled it.
Is that a rebrand or a subcategorization?
It's a great question. And I think they would probably call it a rebrand, but it is a way to think about this problem of obesity as a disease with chronic health implications. And that's what we're sort of trying to do in this space, which is, and there's tons of great examples. For one of the publications that the Hearing Health, the first publication that came out of our group looks at, and there's lots of studies on this one, but just to cite this one in particular, 95% of people know what's normal blood pressure. 97% know what's normal vision. Even cholesterol got 60%, and hearing loss, 9%. And no, everyone else was happy to say that they just didn't know. When people were asked, what were they gonna do for their health in the next 12 months? 95% of people said see their primary care, get their cholesterol checked. Actually, 60% said take their pet to the vet. Again, less than 10% get their hearing checked. Actually, only above listening to a podcast, which was the other one. But and I listen to a lot of podcasts actually. So
yeah, it's an interesting concept. I mean, one of the struggles is talking to some of the researchers is that the lower part of normal is not normal. And so when you're looking at 15 to 25 dB, I can't tell you how many patients I have come in who say they're struggling from a communication point of view, meaning they're actually cognizant of it and they've been told their hearing is normal, right? And some of them get overdriven by audiologic parameters, meaning you put amplification on them, and they're actually very, very happy patients, which is an interesting concept.
Well, exactly right. And sort of where should that line be? I mean, it's not these individuals' fault that they don't know what normal hearing is. You almost wonder, I think it's fair to say some ENTs might not even know. And we're supposed to be, experts in the area.
Well, I'm suggesting to you, maybe we don't know.
Well, there you go.
Maybe the audiogram doesn't actually represent what is a disease state.
You got it. And so what does, and how do we get to that point? And what, even is, what would be a better measure? There have been some stagings. What is, and I'm sure this comes up for you all the time, what is moderate hearing loss? What does that, do we have a sense when some patient says, well, what does that mean? Can we say to them, well, it means you're at increased risk for this, or you might not be able to do this? We don't even, would it be better represented perhaps as a staging system, much like the way that other disease states have adopted? Would that give primary care providers a way to know sort of what to do with individuals that complain about the problem?
Well, I guess philosophically, from my point of view, I think it's the opposite, right? So people know what high blood pressure is because they know what normal is. And so you actually don't need to know what abnormal is. You need to know what normal is. So the answer would be, unless their audiogram demonstrates they're normal, until they're rehabilitated to normal, they have high blood pressure of the brain, otherwise known as hearing loss.
Yeah, that's a really good guess. I guess the question I would ask you is then what, is there a test or a question? One thing that's come up is like, should we really be using a decibel to assess that? What should normal be? What would the right way to answer that be?
Well, I guess I would reflect, some of this is imposing different paradigms, right? So what is the paradigm? What is the measurement for happiness? There isn't one, right? And so the point is it's a multivariant expression of a state. And so, we know there's central hearing loss, right? So meaning that the brain can cause it. So, if you have auditory neuropathy, and so for the listeners, that's a hearing loss that happens deeper in where there's a conduction, the nerves aren't working right to take the information from the ear to the brain. So the point being is your decibels are normal, right? And so, some of it is, I get that people don't know what normal hearing is. I think, sometimes though, I don't know what a normal cardiac catheterization is either. And so what I do is I let the cardiologist discern that. What I really need to know is chest pain, shortness of breath on exertion. What are the symptoms that need to be sent for further evaluation? And, it's only because you've seen a doctor, an ophthalmologist or an optometrist and had them do the formal measurements, do you actually know that 20/20 is normal? So I don't have an answer for you, but I think it's a little bit of a different approach than just the audiogram and expecting primary care providers to introduce that or mainstream that into their diagnostic regimen is a high bar.
You got it exactly. And I think no one appreciates. I would agree. And all of the things that you mentioned have 100% come up as part of sort of navigating the way along what is this. So a lot of people have talked about screening, right? And that's a complicated concept. I'm not an expert in screening by any means, but I think you even had the U.S. Preventative Task Force person, you spoke to them,
Right.
And in terms of the value of screening. But the other thing we know is that, there has to be a meeting between these concepts, because many people, and you know this only too well as I do, don't necessarily identify or experience their hearing loss. They're changing what they do. Yes, they don't feel that they have a hearing problem. Many people with any definition of abnormality hearing
Correct.
feel they don't have a hearing problem. And perhaps that's because the complexity of why that is could partially be addressed by a screening tool that potentially a primary care person could use.
Well, it's fascinating because it's a sensory deficit that we believe people should be able to sense their sensory deficit.
Right. But you can't.
But hearing loss is you do not know what you do not hear. And so the concept of people's self-appraisal, which is, I had a person important in my life who he had severe complications of high blood pressure. And I asked him, I said, well, you had high blood pressure. Why didn't you do anything about it? And his answer was, because I felt good. And so the point being is medical or disease state does not have to be correlated with somebody's experience, right? Because, left arm pain can be angina from your heart, right? Not that you lifted the groceries too hard with your left arm. So I think some of that's the concept of we believe that people need to perceive and actually believe that people need to perceive the benefit to pursue the treatment. And I think that's a misnomer too, right? Because you don't perceive the benefit of being normotensive. You get the benefit of lowering your risk of heart attack and stroke by being normotensive, which is not a perceived In fact, you might have to pee more at night. You might have side effects. You might have a chronic cough. You might have all of these other things as side effects from the medicine. So I think some of it's the paradigm of which we're not necessarily giving the disease to make it a disease. We're kind of injecting the patient as part of the disease when they really, it's like you have an objective hearing loss. I don't need to convince you the graph is the graph.
That's true. I do think and it helps one of the other subgroups. There are many sort of subgroups within this collaborative and trying to take a really systematic approach to this and to flesh out by having experts in the field address each of those things you said. And motivation is a major one. So I think part of it is that we know hearing loss is under-recognized and undervalued, and why by many people, the medical community globally.
Including our otolaryngologic colleagues, to be frank.
There you go. Right. So,
seriously, I'm not, it's due to a lack of awareness, not some sort of active dismissal. It's miseducation, not malice.
Agreed. And so I think I completely agree. And so as working toward that, there's just an intersection of a lot of things and a lot of ways that available. It's also, as mentioned in the collaborative, such an interesting time for that as OTC and other things are sort of evolving now. I think it's a really interesting time in history, or where a lot of these things are going to intersect.
Yeah, it'll be interesting to see. I mean, especially that particular issue where, there already are relatively, cost-free devices in Europe, and we don't see much more penetration. So I personally believe the concept that it's price is a misnomer, but that's my own belief based on the data.
I think that more and more that's actually coming out as well. And, a lot of that has to do with the people that we know that are able to get hearing aids. Well, first of all, that's a very, very complex. Actually, as part of the collaborative, cost was, because of the complexity of it, there's a whole section that's just doing that. But that's not the
What's interesting, if you talk to anybody in sales, every person who is trying to be sold to will always say as their first objection, cost. It's not their real objection, it's their first objection, right? Because sometimes people don't want to reveal themselves as to what the real objection is. So they throw that initial hurdle out always, right? Well, this is too expensive. Right? And so it's an interesting, I'm not a salesman, but when you talk to people about this stuff and you talk to people in that world, that's like the prime objection. So, it's almost like, to me, like that got thrown out there. So people kind of bit the bone and ran with it.
Well, that's so fascinating you mentioned that, because actually some of the HI, like the data that's out there on why people don't adopt, the number 2 reason is they felt why they don't adopt hearing aids is they felt they were being sold.
That's
something.
a different issue.
It is.
Than price, right? So
it's very different. But the intersection of the two gets hard to navigate in this space sometimes, I think.
Well, actually, it's kind of ironic because the sellers of hearing aids, which are the people that sell, they emphasize price, right? They don't emphasize benefit or outcome. And so the real answer to motivate the reason people take their blood pressure medicine is they don't want to have a heart attack. That's simple.
Well, yes, exactly.
And so, same with hearing loss. You want your brain to be healthier, treat your hearing loss. And then, cost becomes a totally different issue if you're talking about the benefit rather than, but it's a big, big topic.
One of the things that I was like, one of my little sections was to look at other like successful health campaigns in the US and in other places. And so smoking is one of the main ones. So sort of speaks to what you said, like, why would you treat your blood pressure, for example? So when, I had tons from my history, this is your brain on drugs. I'm sure you can think of a million really successful ones that you had. And first, there was some good data to say that actually just your doctor telling you.
Oh, it's the number one thing.
Exactly. And
I tell everybody to stop smoking because I know it's the number one factor to get people to stop smoking.
Exactly. And that's
I don't have any expertise besides that. That's my expertise.
Right. Yes. And so that's really good. So how about if we could sort of get a similar analogous thing for primary care? They shouldn't have to interpret audiograms. They shouldn't have to do any of this. But how about they at least know that this is why you should get it checked out or seek it out,
Well, I see that as, it's always these things permeate through what I would call trench warfare, right? It's a 1-by-1 thing, right? Everybody would love to run a national TV campaign and solve the problem, but it's not usually that way. It's peers reaching out to peers and helping peers to understand. So it takes longer and it's more work, but it's actually highly effective.
Yes. And fun.
Well, I agree 1,000%. This has been a great conversation. There are 2 questions I always ask people. One question I always ask is, if you were getting a Lifetime Achievement Award, who would you thank for, they always say, who would you thank? Like, who are the people who helped you to get here and who would you thank?
Yeah, well, that's a long list. I think certainly my parents, they were great supporters. I don't think there's anyone who's successful in life who can't thank their parents. And especially my mom continues to be a source of inspiration. She was a working woman at a time when that was not necessarily standard. Yes. And she has often told me that, in the happiest moments of childhood, our parents are happy also. And so I think that that's really been a super motivating thing as a person with a busy career and kids And professionally, just a long list of people that have mentored me. I think I would maybe give I have actually previously given an award to Susan Waltman, who's a PhD at NYU, has done a ton. She's a good friend. She's a wonderful mentor. She's the first phone call anytime you have something exciting or difficult to report. So that's
well, that's wonderful, right?
It's always good to have those. Have lots of those people.
Those are good people in your life. And then, so what's your favorite sound?
Okay.
We are about hearing and we are about sound. So
yes.
What's your favorite sound?
I would say my favorite sound is laughter. And I would I actually, one great thing about New York City is there's tons of comedy. So I love to go to comedy. We're always laughing in my house. My kids are always laughing. So laughter of any kind.
Yeah, I would agree. And that's actually one of the more common. Some people have some very unique ones, but that is some are very specific. Somebody was the sound of a Porsche 911, which are to them, but I was very like, wow, that's, I'm not sure I could tell that, but they obviously have that ability to discern. So
what's yours?
I do love laughter, and the sound of my children is very good. And ocean, the soothing sound of ocean, which is ironic given that I live in the desert. So, it makes it all the more of a treasured thing. So
that's right. Yeah, makes sense.
Well, this has been great. Thank you so much. This is Dr. Maura Cosetti. She's the director of the Ear Institute of the New York Eye and Ear Infirmary at Mount Sinai and the Cochlear Implant Program at Mount Sinai Health Systems in New York. Maura, if people want to get a hold of you, where would they get you? LinkedIn, or how do people get a hold of you?
Yep, any of those things. LinkedIn with my name at the Mount Sinai website. My email is on there. You can reach out to me electronically anytime.
Well, this has been great. Thank you so much. I really appreciate it. It's been a fun conversation. Great topic, something I'm really interested and passionate about. Thank you so much for coming on.
Thanks a lot. Thanks for having me.
Thanks for tuning in to the Listen Up podcast. We'll see you again next time, and be sure to click subscribe to get updates on future episodes.